Each year, more than 1.5 million Americans suffer from a myocardial infarction or MI, and despite aggressive treatment at the time of MI, up to 20% of people have symptoms a year later. There's a high financial cost of ischemic heart disease in the U.S., about $177 billion in 2010, and more than 50% of that was due to hospitalization, of the direct costs is due to hospitalization. Now, in addition to that, there have been data that have shown racial and gender disparities in both risk factors for MI as well as treatment of and outcomes after MI, and there are gaps in 30-day readmissions. So whether gender and race affect symptoms after MI and hospital use within the year following MI has not been studied. So that's what we wanted to look at. The data for our study were from Translate ACS. This is an observational study of MI patients, both ST segment elevation MI and non-ST segment elevation MI patients who were treated with percutaneous coronary intervention, or PCI, and an ADP receptor inhibitor during their hospitalization. Translate ACS enrolled patients from 233 hospital sites in the U.S. between April 2010 and October 2012. And patients were followed up by phone at 6 weeks, 6 months, 12 months, and 15 months. And they were asked a litany of questions, but we also had data on rehospitalization, which was verified by medical record and billing. And so this, to us, represented a very ideal population to study our questions. We studied about 11,600 patients in total. Among this population, 66% were white males, 24% were white females, 5% were black male, and 4% were black females, approximately. In general, the females had lower baseline quality of life and higher rates of depression than males. Blacks had higher rates of no medical insurance and unemployment, and higher rates of comorbidities compared with white persons. And overall, almost a third of patients had angina up to 1 year after MI. When we looked at rates of angina frequency and treatment, we found that blacks in general had greater use of calcium channel blockers and nitrates, but less use of beta blockers and less referral for cardiac rehab compared with whites. We also then looked at 1 year unplanned rehospitalization and found that in general, blacks had greater rates of rehospitalization than whites, and females had greater rates of rehospitalization than men. So black females had the greatest rates of rehospitalization at 1 year, and these are unplanned rehospitalizations. The last thing that we found was that one of the factors that was most strongly associated with unplanned rehospitalizations at 1 year was the presence of angina at 6 weeks. And that relationship was not modified by race or gender, so held across all the race and gender groups, which was really interesting. So I think that actually, that last finding that I alluded to was probably the most striking because, as I mentioned as part of the background, there have been gaps in 30-day readmission rates between the genders and the races. And so here we found that there are gaps in 1 year unplanned rehospitalization, but that 6-week angina is very strongly associated with that, but that's independent of race or gender. So really, the differences in angina may actually be contributing to the differences in the downstream rehospitalization and hospital use. And so I think one of the take-homes from there is that if you treat angina after an MI, it will reduce hospital resource use for all, in particular for blacks and females, but for all. There are a few take-homes in addition to that. I think one is, as a practicing cardiologist, symptom control after a myocardial infarction is a treatment goal. And we found that a third of revascularized MI patients still have symptoms up to 1 year out. So I think that's one important, finding that suggests we really need to focus on optimizing angina treatment. Second is that, eliminating racial disparities is actually a national goal. It was on the 2010 Healthy People's Agenda, and we've documented that they still exist. So I think that's another area where we need to focus our attention. And as I said, thirdly, I think, treating angina as a general rule is actually potentially a way to reduce resource use downstream after an MI. And I think part of that is important because, as you know, readmission is a really hot topic right now. But angina represents a modifiable and achievable risk factor. So I think that's really something that we should pay attention to.